Welcome to this session on fertility, pregnancy and bariatric metabolic surgery. I'm John Dixon, I'm from here in Melbourne and I've worked across a lot of areas in obesity research, but the most important thing is to get a transdisciplinary approach to managing pregnancy and the issues of pregnancy and infertility and fertility on the context of pregnancy. And we all work in silos. We all tend to work in silos. In fact, most specialties work in silos, and we don't share our languages at times and so forth. So I think it's really, and we get into conferences and we share our own perceptions, myths, beliefs, and support ourselves, and we go down a pathway. I think it's very important to get groups of different people with different skill sets together to actually take a transdisciplinary approach to important areas such as obesity. It's a chronic disease. No specialty owns it, by the way, despite the fact that endocrinologists seem to have an interest in it. No specialty owns it, as you know, the levels of stigma and you know the lack of uptake. So it's what we need to be looking at today is how to cope with the issues of reproduction in women, the fertility, infertility, and before, during, and after pregnancy. And so we've got our first speaker. My deputy chair is Paulina Salamina. She's from Turku University in Finland. She's a surgeon, and let me say I'm very impressed that she is one of very few really evidence-based surgeons. So we're going to have...
That doesn't really say much for surgery, but...
So our first speaker is going to be Ben Mole. Ben's an obstetrician and gynecologist, a researcher. He's got an incredible track record. He's from Monash University here in Melbourne. His accent might suggest he's been somewhere else. He's including his area of O&G, he's infertility, and then of course he's actually written about and researched issues of obesity in pregnancy. Ben.
Yeah, thank you, John, for that kind introduction in my hometown. And maybe before I start, first asking who is the non-evidence-based surgeon in the room. So obesity. So I'm an obstetrician gynecologist, but I do clinical research as my core business. I consider my core business making medical knowledge. And I've done studies on obesity and infertility, and I will discuss that from that background. See if I can get the slides moving. Yes, here are my disclosures. I don't think relevant for this talk. And then I will make some comments on fertility and obesity, talk about lifestyle interventions, IVF and obesity. I will touch upon David Barker and the Hunger Winter study, and end with bariatric surgery. And my main aim is to give you some facts about fertility and reproduction and obesity, because I think there is a lot of prejudice going on that is actually harming overweight and obese women and people. So to start with fertility and getting pregnant, I don't have a slide on that, but overweight and obesity are important drivers within polycystic ovary syndrome, which is the situation where ovulation is not happening or happening with a decreased frequency, and therefore it's difficult to get pregnant. But apart from that, we have looked in a large cohort of women who were ovulatory on the association between body mass index and fertility. And you can see here that being too light, but also being too heavy, has an impact on your fertility, with an optimum on a BMI of 25, and then over that there is a slight decrease of fertility even in women who have an ovulatory cycle. On then to some slides on IVF. I will say something about thresholds for going into IVF, because there are clinics who says that over a BMI of 30 or 35, one should not allowed into an IVF program. We have reviewed the literature in terms of complications, and we don't find any indication that obesity in itself increases the risks of complications from IVF in terms of the puncture, getting eggs, OHSS, multiple pregnancy, and ectopic pregnancy, as demonstrated on this slide. This is a series of studies that report on the chance of getting ovarian hyperstimulation syndrome, OHSS, in women with a BMI over 25, and you can see that there is really no increased risks. Another idea is that the chances of getting pregnant are lower. That is true, but only to a limited effect, as can be seen here with an odds ratio of 0.9 that just touches upon statistical significance. And to demonstrate that impact of weight as compared to age, this slide where you see that when the age goes over 37, but specifically over 40, the success rates of IVF really drop. And the impact of obesity is there, but to a much lesser extent. So from this information, there comes the idea that lifestyle intervention before fertility treatment is a good thing, and maybe even should be endorsed, but maybe even should be enforced. And that was the reason that when I was in the Netherlands, which you might, John, see for my accent, we did a large randomized clinical trial in infertile obese women, randomizing them for a lifestyle intervention or immediate start with fertility treatment. That study had close to 600 women participating, but importantly, we did not see benefit from the lifestyle intervention. In contrast, the live birth rate, the primary outcome of a vaginal birth, was 27% after the intervention and 35% after the control. So even a little bit of harm. And if we took into account all live births, also those born after cesarean section, and the preterm ones, then the picture was the same, 44% live birth rate with the intervention and 54%, so 10% higher without the intervention. Importantly, the miscarriage rate was higher after the intervention group, and I think we should be very careful with severe weight loss just before getting pregnant. Here you see the same data, but now in a Kaplan-Meier curve. On the left side, the vaginal birth at term alone. On the right side, all live birth, and statistically significant disadvantage of the intervention group. This is a supplementary table from the same article. Important to see if this pointer works. To see that the natural conceptions, so those without any other medical intervention, are a little bit higher after the intervention group. I think that comes from the 6 months time that was taken for the lifestyle intervention. And there is also less ovulation induction as compared to the control group, which potentially means that this is although there was no overall effect, there is a beneficial effect in women with PCOS. So that was the study that we did, but then many other people have done similar studies, and they've been recently summarized in this meta-analysis in Fertility and Sterility. And overall, there seems to be a benefit of the lifestyle intervention with a relative risk of 1.24. That happens similar in lifestyle interventions and pharmaceutical interventions. If you look into live birth as an outcome, then the benefit is there with a relative risk of 1.19, but it's just not statistically significant. I don't think you should therefore say that the treatment doesn't work. And again, there is the similar impact potentially of the lifestyle intervention on miscarriage. Now, we are doing so-called individual participant data meta-analysis, where we do meta-analysis with the original data. This is going to be, the results are going to be presented next month at ASRM. I can't show the results, but our analysis shows that the benefit of the lifestyle intervention is in the women with PCOS and not in the women without PCOS with unexplained infertility, which is an important message. If you have a discussion if obese and infertile women should be at a particular threshold, not have access to fertility treatments, I disagree with that for three arguments. It is said that it is a risk for the mother. Yes, obesity has a slightly increased risk, but so does women who have diabetes or women with previous preeclampsia, and we still give them treatment. Risk for the offspring, yes, it's there, but not so severe that we should withhold treatment. And finally, the decreased success chances, yes, a little bit lower, but as I showed you, the impact of female age is much stronger, and still we give fertility treatments to women of 40 and higher. A couple of comments to close before I go to bariatric surgery. This is David Barger, who is a hero. In my opinion, against all odds, he formulated the hypothesis that intrauterine health or intrauterine conditions were important for health later in life. This is one of his first papers where he compares infant mortality in a particular region in the UK on the x-axis to cardiovascular death later in life. He was completely denied. He had to write letters to himself to convince him that he was right. And as far as I'm told, the last words before his death were Oxford, because that was the group really that disagree with him. He was in Southampton. But he proved to be right, because after his hypothesis in Amsterdam, the hunger winter study was done, where by Ravelli and Rosenbaum and others, the impact of famine on later health of the children born in the Dutch hunger winter were shown. And you can see the design of that study. So there were basically women on the left side pregnant in early pregnancy, mid-pregnancy, and late pregnancy. And on the right side, it was found that there are enormous consequences for later life from famine, specifically in the first part of the pregnancy, early gestations. So glucose intolerance, but also obesity, cardiovascular disease, breast cancer, not on this slide, suicide and income are all increased if you are in the beginning of pregnancy exposed to famine. Now that is important to keep in mind, my last couple of slides, if we look at bariatric surgery, because that is a very radical intervention. Obviously, prior to pregnancy, we have good data from Scandinavia, from Sweden, that compare pregnancies after bariatric surgery as compared to a control group. There are beneficial effects from bariatric surgery on having gestational diabetes, being large for gestational age, macrosomia, so that all happens less, but there is more small for gestational age, more low birth weight, and more stillbirth in these groups. And that is not really related to the duration of the time since the surgery. Still, I think, based on the data from Barker also that I showed, that I would potentially advise to delay pregnancy a little bit after bariatric surgery and don't let somebody conceive immediately in the period where the effect is strongest. Finally, there is also some impact of a beneficial impact of bariatric surgery on congenital anomalies, and this is my last slide, John, so back to you.
So discussion at the end, right? Yeah. Okay, we'll have the panel discussion at the end, and it's my pleasure to introduce the next speaker, who really does not need introduction. So, Mary O'Kane, well known to IFSO, currently part of the IFSO Executive Board, past president of the Integrated Health, and she will be talking about nutritional guidance before, during, and following pregnancy.
Thanks for inviting me. I had sort of my presentation done. I was given 5 minutes, and then John and I had a Zoom call, and he said, "Oh, nutrition's important. I'm giving you a bit longer." So, but I don't have the answers, but might raise lots of questions. So, with bariatric surgery as a dietitian, often it's left to us to actually speak to patients about bariatric surgery as to whether they're going to get pregnant and contraception and all those things that I never thought I'd be talking about as a dietitian. But also just checking with them, are they planning to get pregnant soon? A lot of them think they will never get pregnant, and so therefore don't use contraception, so that can be an issue. And ideally, we'd like people to be weight stable, have a good nutritional intake, and obviously we focus on folic acid, trying to cut down on vitamin A, and the usual dietary advice to go with pregnancy and preconception. However, then there's the reality of it, and certainly in the UK, we have anyone going for fertility treatment, it's age restricted, so 40, in some cases 42. And so for a lot of women, that's going to be, they might be coming in their 30s, trying to lose weight. So you've got this sort of time against you. And although we might advise people not to become pregnant in the first year, one study suggests that many do. And I think in the UK, we're not too bad, but people do get caught out. And also in the UK, we would give a maximum of 2 years follow-up. And most people then are actually outside the bariatric centre. So trying to get referred back in and trying to get referred back in timely is difficult. And I have had presentations where they say that ideally everyone should have that preconception planning and see somebody regularly beforehand. But in the UK, that doesn't happen. I don't know if anybody else manages to do that. And then also about having nutritional blood tests. And also, just because someone is thinking about getting pregnant or has had surgery, the nutritional intake may not be better. And I think it's quite interesting hearing what Ben's saying about fertility treatment, because in the UK it's definitely restricted to BMIs of 30 or below. So if you've had a woman who's maybe started off the BMI 50 or 60 and has got down significantly, she still may not meet the criteria in the UK. And just before I came out, there was an article in the paper just saying how unfair it was. And this headline, and this was a woman with obesity who lost weight successfully and did very well by diet and lifestyle. But because her BMI was over 30, she couldn't get fertility treatment. So she put herself on an 800-calorie diet to actually get down so she could actually have a fertility treatment. And she actually talked about how poor her diet had become. Then when women get pregnant, we have the usual morning sickness, and the eating little and often will often work. But also I find that sometimes I'll get called by someone who says, I've been pregnant, I think I've got dumping syndrome. But when I check, they're on a quite high protein diet. They've really restricted the carbohydrate. And then talking to them about eating normally again and actually including some starchy carbohydrates and actually having some snacks in between. And it's not dumping syndrome. They're just actually probably just not eating enough, but they're so afraid of putting weight back on again, they try to still restrict their intake. Hyperemesis, not my area, but the one thing I'd be concentrating on is making sure that we actually give thiamine supplements and obviously making sure that they get that support. And then also we've had a few women who've never had postprandial hypoglycemia, and then they've had GTT even after a sleeve, gone massively hypo and then struggled. And in Leeds, we just tend to do monitor afterwards rather than doing GTTs for people who've had bariatric surgery. Macronutrient deficiency can be common in pregnancy, and women who've had bariatric surgery can be more at risk. And as I said, just because someone's had bariatric surgery does not mean that they're going to eat healthily. And also it doesn't mean that everyone has been taking the supplements before becoming pregnant either. And then anemia, we know it's very common, and it's not just about the iron deficiency anemia, it's about the effect of B12 and the effect of folic acid. And I think many people will know that we recommend additional folic acid to try and reduce the risk of spina bifida. We also got to be careful with B12 because of that as well. In England, the National Institute of Clinical Excellence are currently reviewing maternal nutrition and obesity. What's quite interesting, they have finally reviewed folic acid, because when we're doing the BOMS guidelines, the evidence base for 5 milligrams of folic acid for obesity, it's not there. And they're now accepting that. And so the recommendation, which is out for consultation, is actually for preconception planning and the first trimester of pregnancy is 400 micrograms for women with obesity. Interestingly, when I went to look at their evidence base, the reason why it's 5 milligrams for obesity and diabetes in the UK is because that's the tablet that they make, that's the dose. It's not based on real evidence. And then moving on to vitamin D is really important. Do we actually know the optimum level of vitamin D that we want after bariatric surgery? In the UK, we're aiming for 75. Could be 50. We don't actually really know what it is. Also, we know that women will need more calcium during pregnancy. Do we actually know what they need after bariatric surgery? And also, certainly with our surgeons, I'm always trying to remind them that if you've got raised PTH and vitamin D is normal, it's actually calcium you need to concentrate on. And there is a nice calculator where sometimes you can get people to actually tot up their own calcium intake, because they don't always like the calcium supplements as well, so you can try and get that from the diet. Vitamin A. Sadly, NICE has not reviewed vitamin A, and this is one I really struggle with, because we know vitamin A deficiency can occur after bariatric surgery, can be linked to night blindness, it affects fetal growth. But also, if people have excess vitamin A, we're concerned about it. WHO give varying amounts. SURE's pregnancy guidelines recommends restricting vitamin A and also making sure that we're having a beta-carotene form. However, the challenge I have is if you're seeing somebody who's had a duodenal switch, who's on quite a high dose of vitamin A, needs to do that, what we're going to do, and just trying to make sure that we can get in a beta-carotene form. So it is difficult, and I just wish NICE, the National Institute of Clinical Excellence, had actually reviewed this area, because it's controversial. And if you're a dietitian trying to manage this in pregnancy, it's really scary. And this is a slide that I found back from 2007 with some patients who had had a duodenal switch. You can see that one of them was actually, we discovered, must have been 5 weeks pregnant at the time she had a duodenal switch, and she lost 89 kilograms during pregnancy. Others were a bit later, didn't lose quite as much. And I just remember being terrified throughout their pregnancies because I didn't know what the outcome would be. We were using a vitamin and mineral supplement that had vitamin A in a high dose in a beta-carotene form, but at that time I couldn't request vitamin A. So it's how do we manage these women who are going to be more at risk? Also, the SURE guidelines, which are excellent, they recommend that women planning pregnancy should have bloods done every 3 months. How many of you will manage to do that? If it's like the UK, people present when they're actually quite several weeks pregnant. So if we manage to get one lot of bloods done during the pregnancy, we can be lucky. Also, they're recommending checking INR, but in fact, INR is not a good indicator of vitamin K. You should be checking vitamin K. And I think these guidelines are excellent, but in reality, I don't know how practical they are, and I'd be very interested to know what we should be doing. And then just really to say that ideally, we want timely preconceptual advice. Many of the women will talk at the beginning, they don't believe they're going to get pregnant, and then they get pregnant immediately after surgery, or they come back a few years later already pregnant. We need to get that timely communication, and how do we do that? And in the UK, we recommend, obviously, women with bariatric surgery will have access to specialist antenatal care. That has got better. Years ago, I had one of my patients who was told by somebody quite junior to consider aborting a baby because she'd had bariatric surgery. Fortunately, she saw a consultant who said no, normal pregnancy. And it's just how do we work together to achieve this? Thank you.
Thanks, Mary. We're now going to go to a surgeon, Ido Arts. Ido's from the Netherlands. He's a surgeon, and he's also very interested in nutrition. And so he's going to talk about the surgical issues and so forth, and the perspective of a surgeon. And of course, we have another surgeon here that we can discuss these with, and they can fight one another later. Ido.
Thank you so much for the nice introduction, John. And I must say that last night you gave me a call and said you have 5 minutes. So apparently you don't find surgery that interesting, right? Well, okay, let's give it a try at least. Very warm welcome. Being a surgeon here means that I'm going to talk about surgery. Hopefully I can grasp your minds a little bit about the very, very little chances of getting into trouble because of the surgery itself during actually your pregnancy. Now, of course, this was the title given. Hopefully it works. Yeah, there we go. There we go. So we're gonna focus on the complications during pregnancy, right? So you had bariatric surgery. And of course I have to disclose. I'm always a little bit afraid of people who have nothing to disclose, because once you had one dinner over 50 euros, you have to disclose with industry. Well, in general, we have a lady that is undergoing bariatric surgery, and she, in this case, got a sleeve, went on to life to lose a lot of weight, and luckily for her, she found her love in her life. 9 months later, she was doing pretty well, but of course, you have a sort of preconception consultancy, hopefully before that, but that's not how Tinder works, right? So, this patient unfortunately came because of abdominal pain, and she was quite worried, of course. Now, I can imagine, of course, and one of the first things that people think about is, of course, their surgery. I don't know why, but it always is. So they get referred to me, and I don't know whether that's a wise choice, but as a father of 4 girls, I can relate. Now, talking about timing, of course, so I have to do some sort of surgery somewhere. Probably everybody in the room already knows, but you have a sort of 3 trimesters, of course. And as a surgeon, you only have to remember 1, because those 2 you do not operate, because in the first trimester, because of the anesthesia, there's a bigger chance of getting an abortion, let's say, which is quite unfortunate if you're intending to keep the kid. And the 3rd trimester, of course, the uterus is so enormous that doing laparoscopy is quite difficult. So there's a golden moment in time, that's the 2nd trimester. Of course, you'd rather not do any surgery at all in patients who are pregnant, but if you have to, then make sure that you either, if they are in the 1st trimester, try to get to that 2nd trimester because of the lower risks, etc. And yeah, unfortunately, in the 3rd trimester, you have to sometimes stick till the end. But it depends, of course, on what the problems are. So the most common reason to do surgery after bariatric surgery in a patient who has undergone a procedure is a gallbladder issues. So I had my fair share of them. And it's not funny, because normally it goes away after, let's say, a couple of hours. You give some morphine, but there are patients that on and on and on and on keep on getting those stones out. And that means that you are in trouble, because those ladies have to be admitted to the hospital, especially when they're in the wrong trimester. And we try to at least either get them to the 2nd trimester if these attacks keep on coming, and otherwise we pull them through. Now, going on surgically specific, I'm only going to discuss these 3, putting in the band there. No, not a single patient, I think, in the Netherlands still have them, but because of your legacy, let's say, and John Dixon, there's probably some around, even in the fertile phases of their lives. Again, it is very, 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 very uncommon to have any issues, but pre-consulting is a very good idea, so please do that, and also tell them about the risk that it is thus very, very, very uncommon, but they're always allowed, of course, to reach out. Starting with the band, I'm not going to focus on nutrition, etc., of course, pure surgical. Most important one is probably slippage. What you get is that part of the stomach slips through the band, and it can be necrotic. I've only seen that once, so don't worry that it doesn't happen that often. Then you have to wait a very long time. You just deflate the band, hope for the best, let's say, and only in very, very small cases. I've never come across them, and I must say I didn't find any in literature. You sometimes have to do emergency surgery. Second issue, I will not show you the inside pictures, but you have something called band migration. Normally, if the pointer works, normally this part, no, I can't see it, but the upper part that's normally on the angle of issue sew over the band, and that is quite often where actually the migration is. So it migrates into the stomach, and then you have an open connection, let's say, from inside to outside. If that happens during pregnancy, I could only find one case report on it. Then you can endoscopically remove it. You go via the mouth with a sort of wire saw. We use them for bones and for removing bends, let's say. And you can give some antibiotics, but it's a closed environment. So normally there will be no leakage into the abdomen itself. So emergency surgery, I would not expect doing that here, only if necessary. Sleeve, that's the reason why it's probably quite popular, or it has been quite popular in advising patients to undergo a sleeve if you want to get pregnant. You can get, if the uterus is relatively big, a sort of kink in the region where the crow's foot also is, because of the uterus going up, and it's relatively hard to get any fluids in. But again, never do surgery, just give a nasal tube and feed them through that way, or give them additional water, let's say. The most scary one, of course, I don't find it very scary, but the most scary is any type of bypass, Roux-en-Y. Why? Why? Because we as surgeons were lazy. When you make a hernia is just a hole in a human body that should not be there. There's many of them in the back, everybody knows, your groin hernia, umbilical hernia, it's all called a hernia. And as a surgeon, you can make a hernia by attaching two parts of the small intestine in an anastomosis, but there's a hole behind it, and you have to close that, but for the first 10, 20 years nobody did, and now we found out if you close it, the chances of getting an internal hernia drops down to somewhere between 1% and 4%, depending on how you do it. But again, there's two spots that you can have an internal hernia. That is over here, and you have, I wrote a very nice article on it if you want to see and do it or read about it. You have 24 different types of internal hernia, depending on what herniates around what, and you can have a hernia over here. The upper one is relatively 50%, and the lower one as well. The upper one is relatively more seen in pregnancy, because then the enteroenterostomy, so the second connection, go through Peterson's space. Everybody thinks it's an American, but actually he was Danish or German, I think. I would suggest in the first instance to do observation, especially when they are in their first and third trimester. But if it doesn't work out, if you see the infection parameters go up, you have to unfortunately do emergency surgery. And I can tell you in the third trimester that's not funny, because that means a laparotomy. In many cases, you always begin laparoscopy. Sometimes you will be able to achieve it, and if you wait too long, it can become necrotic. I have never seen that, but that is probably because we don't wait long enough. Perhaps the solution for all the problems is this one, OOGB. Gonna keep it short. There's only a theoretical proportion that can herniate here, but it's 0.12%. When you close it, so considering the 1 to 4%, that's a lot less, and it's only theory because there's nothing written on it. Again, hope I didn't waste your time. Thanks for the attention.
Thanks, Ido. That's terrific. We'll chat later about.
Yeah.
We will. No.
Okay. I'd like to introduce Bryony Hill. Bryony's a psychologist, someone who works in the area of weight stigma. She's part of our stigma team. You may have heard her yesterday afternoon in the integrated health section. But her focus in stigma is women, and women prior to, during, and after pregnancy, and some aspects of infertility as well. So that's her research group, and she's going to give us some background as to what's out there and what we can do about it.
Thanks, John. So weight stigma, if we all hear the term, it's bandied around quite a lot, but can be a bit hard to grasp sometimes. So it's the phenomenon of discriminating, stereotyping, excluding or devaluing somebody where their weight does not comply with the prevailing social norms. So in Western society, and indeed in non-Western societies now, that is that ideal of the thin body. Oh, there's my conflicts, which is the ARC. So in terms of preconception fertility care and pregnancy, weight stigma is extremely prevalent. Weight stigma occurs, so women report a weight stigmatising encounter almost at every healthcare visit during pregnancy and postpartum. The reproductive years are a period where people are particularly vulnerable to weight stigma because of the weight gain associated with pregnancy and postpartum. They experience weight stigma across all aspects of their life. As I mentioned, particularly in healthcare, it's quite prevalent. And the stress of stigmatisation has serious and adverse consequences across physiological, psychological and behavioural responses. So it affects your mental health, stress, depression. It causes people to engage in suboptimal health behaviours, which then reinforces those behaviours and also can contribute to weight gain. So women tell us a lot about their stigmatising experiences, and while it predominantly affects women in larger bodies, it can be experienced by women across all body sizes, particularly in terms of weight bias internalisation, which is internalising that stigma to yourself. So feeling like the societal norms around body size, that they belong to you as well and that's your fault. So women report feeling hurt, judged, shamed, embarrassed, humiliated. You can add any adjective in there. And weight stigma often happens because people are individually blamed as responsible for their own weight and any issues that arise in pregnancy and preconception, and indeed postpartum as well. And we know that that's not the case because body size is mostly genetically determined, there's an environmental component, and individual responsibility is one small aspect of body size. But that blame narrative continues, and it's particularly important in pregnancy because once you're pregnant, you can't change your preconception BMI, can you? So we need to forget about that and just treat the woman as you see her and with respect and woman-centred approaches. So women report that people, clinicians, will look at them in their appointment and make assumptions about them, about their food and exercise habits, that they're lazy, that they don't have any self-control, and often this is done without even asking them about their behaviours. So what are the health and social impacts of weight stigma? It very clearly and explicitly leads to lower quality of reproductive health care, and that includes doctor shopping, women disengaging from healthcare, starting their first antenatal appointment much later than they should be. I've mentioned mental health, stress, body image concerns, affecting health behaviours and coping strategies. But we also believe that weight stigma during this reproductive period can implicate in poorer birth outcomes, adverse impacts on breastfeeding, and longer maternal and child health outcomes. So I know it's all doom and gloom, but I want to reassure you that it's not our fault. It's not your fault. Weight stigma is everywhere. It's ubiquitous in society. You can't escape it. It's in our societal norms and social norms. It's the way we talk to each other. It's the media. It's also in the policies and guidelines that guide the way we work and do clinical practice. And so, for example, some hospitals have a policy that women who are over 100 kilograms can't birth there, they need to go somewhere else. How does that make that woman feel? How does the clinician have to deal with that? That's a policy that's outside of the individual control of that person, but it does exist. And guidelines are very stigmatising in nature. They use a blame narrative. Their discourse around weight is very stigmatising, and while we're doing a lot of work to try and change that, as we were just saying, it's really hard to, policies take ages, they have to be reviewed, they have to be updated. And finally, education and training. Where was the stigma education that when you went to uni? Where is it now? We're working on it, but it means that it's taking time and we all need to get there eventually. But in the meantime, if we can recognise our biases, our maybe stigmatising attitudes or behaviours, then we can do something about them. We're doing the vignettes, John, at the end?
We'll do it at the end.
Yeah, all right, that's me.
Thanks, Bryony. There are some seats down the front here, right down the front, if people at the back are looking to get some rest. Right down here. Okay. Next, I'd like to introduce Professor Louise Bauer. Louise is, well, I can't explain how detailed her knowledge of obesity is. She's a paediatrician who's worked in management of childhood and adolescent obesity. She's also very focused on preventing obesity, and she's working, and she's even interested in our stigma stuff and so forth. So I really think that and she's immediate past president of World Obesity. So Louise, tell us about adolescence and your perspective on this.
Okay, thank you very much, John, and it's great to be here at IFSO. Oops, now I've worked out. These are my disclosures. I want to tell you about some issues that you need to take into account in interacting with adolescents, particularly adolescent females who have obesity and who may be considering bariatric surgery or other forms of obesity treatment. The most important, I think, is to realise that adolescence is a period of major brain development. There's a picture here, under construction until 25, and I think we can all agree with that. And it may be, and I suspect it continues to be under construction for all of our life, but there's an enormous change during adolescence. So by mid-adolescence, you may expect some degree of maturation of the emotional brain, which looks at the control of reward-seeking, hyperexcitability and proneness to impulse. That improves during the adolescent years. But the development of the prefrontal cortex is something that continues until the mid-20s, and that's responsible for planning, organisation, looking at risk versus benefit assessment, the ability to delay immediate gratification for future gain. Now, these are all things that we recognise as really important in many aspects of life, including when considering treatment, surgery, etc. Therefore, treatment programs for adolescents need to recognise that choices are often based on emotion or impulse. Should they be? There are difficulties in consistently following through action plans. There's a relative inability to comprehend future health risks. In my clinic, I'll talk with the young person, it's all about now, and I talk to the parent and it's all about the future risk of diabetes and heart disease. Totally irrelevant to the young person. What they're worried about now is how they get on with their mates, how different they are, and things like that. That's where my conversation with them needs to be. They want to be like their peers and want to be independent. At the same time, family support remains vital. And so this issue about how you interact with both. Now let's think about fertility and contraception. Some adolescents with obesity may be truly sexually naive. I don't know of studies looking specifically at adolescents with obesity in terms of their sexual experience. And therefore the change in sexual attraction or experience or the fertility after weight loss may be totally unexpected and needs to be discussed sensitively beforehand and ongoing so that it's not a surprise. We are aware of studies of bariatric surgery in adolescents where the young people developed pregnancy. I don't know the stories behind those, but we shouldn't be surprised that adolescents may become pregnant. At the same time, some adolescents with obesity may already be sexually active and truly believe they do not need contraception because they believe that they're infertile, and they may have subfertility at that moment. And therefore the expected changes in fertility after weight loss will need to be really highlighted before it occurs, and the adolescent given contraceptive advice. I also want to just highlight the issue of weight stigmatisation. It's widely experienced by adolescents, by people living with obesity, and it's delivered by family members, by teachers, by peers, by health professionals and the health system, us, and the general public, and it results in barriers to seeking and receiving treatment and worsens treatment outcomes. And so there's a really important role for the health system here. It really highlights the importance of the clinician role modelling. What can we do to role model a supportive, non-stigmatising approach to our patients, about using appropriate language, about how we incorporate behavioural health screening and how we talk about it, and ensuring a safe and welcoming environment for people in larger bodies. There's also the important issue of transitioning to adult services. It's a big gap. Adolescent services tend to be youth and family centred. They tend to be potentially a little bit paternalistic or maternalistic in their approach. Adult services are very different in their approach, and maybe neither are really good at engaging and keeping adolescents engaged, and we are really poor at actually transitioning from adolescent services to adult services. And so we need to think about that. We need to plan and coordinate processes to transition young people with chronic diseases such as obesity into the adult health system in order to optimise continuity of care, and that's often not addressed. And there's a higher risk for poorer outcomes for many health issues post-transition. So these are some of the general principles of adolescent care. So what are some of the implications in terms of our conference this week? So please be developmentally aware in working with adolescents. They're not a 4-year-old, there might be a 14-year-old, but a 12-year-old boy may be very different from a 16-year-old girl. So think about where this young person is. I think it's really important when you're dealing with adolescents to work with a multidisciplinary adolescent clinical care team somehow. Focus on the more immediate rather than longer-term needs and issues, at least to begin with. Please ensure that adolescents seeking treatment for obesity actually receive contraceptive advice. Think about how you can address weight stigma in a range of ways, and please plan for transition from adolescent to adult clinical services. Thank you.
Thanks, Louise. Last but not least, Teresa Girolamo. Teresa is a general practitioner from Adelaide, but she has a long history of working with bariatric surgery, weight management, and of course managing women pre and during and after pregnancy. And so she's the coalface, and she's going to give her perspective, and then of course we've got to focus on what she wants to know and how she needs to use all of us down the track. Thank you.
Thank you, John. And yeah, thank you. I think this is a great turnout, and this is relevant for all of us in this setting. So thank you for coming. No conflict specifically related to this talk today. Now, what I really wanted to look at was actually the patients and their experiences and their needs in pregnancy post-bariatric surgery. And there is a paucity of published articles on this. So I combined those published articles with the experience in our own clinic. We see a lot of women in that childbearing age, and I think we manage our patients very well throughout the pregnancy phase and the post-op. And so I wanted to look at themes from the published papers as well as themes from within our clinic. And so I've categorised them into three. So women often described information gaps, and so that was preconception. Not so much in our clinic, thankfully. Fears, and this really related to discussions with women in our clinic. And then the last one, again, more from the published papers, was the experience within their healthcare team. And we get this consistent feedback as well from our clinic, in the experience in either private settings, seeing their obstetrician, or in public hospitals. So we'll look at each of them a little bit more. So if we look at the information gaps, the common themes were lack of contraception advice, lack of adequate contraception advice, and I know this was talked about yesterday as well, and I think it's absolutely crucial that we talk about that well and truly before the patient is having bariatric surgery. Lack of family planning advice and poor understanding of the waiting times after metabolic bariatric surgery. And again, we've talked about this and we know about the guidelines, and there's different guidelines from different societies. It varies between 12 months and 24 months, or some just say once the weight is stable. But I think women are actually understanding why some of those directives are put in place, and actually discussing it with the woman, what her wishes are, again, before bariatric surgery, so that she knows what those expectations are. But I think the patient needs to know that we will support them no matter what. And there was a theme that some women felt really frightened going back to their bariatric clinic if they fell pregnant within that first 12 months. And so they got very poor care because they weren't being nutritionally monitored in that first trimester. The nutritional care during pregnancy, we've heard some great information about that already, but a lot of women felt it was lacking, and it was also certainly lacking when they went to the obstetrician or the tertiary hospital. And lack of tailored breastfeeding advice. And in fact, one study showed that 96% of women gave up breastfeeding within 5 weeks of delivery, and because they largely felt that their breast milk wasn't going to be adequate for the baby, which is not correct. So talking to our patients, the fears. So this is both pre-pregnancy and during the pregnancy. Of course, an obvious one that we all talk about and that we all as clinicians worry about is the fear for the well-being of the baby, the nutritional, parameters, the risk of small for gestational age babies. But I've delved in more to actually how the woman feels, and she may not actually talk about this unless we bring it up. So the fear of judgment, and there's that stigma that Bryony so nicely talked about, and our own internal biases, even as healthcare providers. Fear of gestational weight gain is huge, and women feel really conflicted talking about that. So I think we need to bring it up and let them know it's normal and it's expected and that we can help them. Fear of inability to lose the gestational weight afterwards as well. And again, I think talking about that early so that they feel more comfortable. And fear of reduced ability and time for self-care postnatally. I think after bariatric surgery, we often talk to our patients about how self-care is so important, particularly in that early phase where we're all throwing 1,000,001 rules at them, separating food and fluid, having enough protein. We've got every member of the team, asking them to do something slightly different. And we are focusing on their self-care, and we're not all good at self-care. And suddenly they're going to have a baby and there's not that same time for routine and self-care. And that's really challenging for these women. And then if we look at the experience with the healthcare team, it's just put into 2 broad categories. Lack of knowledge and experience from the healthcare providers, the midwives, the obstetricians, the paediatricians, and experience again of judgment and blame. If if the baby's not growing well and they're seeing a dietitian who hasn't got specific bariatric advice, they may not understand the requirements of an eating pattern once you've had bariatric surgery, and they can feel blamed that they're not eating enough and they're to blame for their baby not growing well enough. So I'm just going to focus a little bit about that gestational weight gain because, as I said, I think this is so important that we actually raise this with our patients. Regain in general following metabolic bariatric surgery is a known problem in a substantial number of patients independent of pregnancy. If we look at the actual consensus guidelines when talking about gestational weight gain, We're told that it's important to avoid excessive gestational weight gain and postpartum weight retention in women after metabolic bariatric surgery. But then we're also told that insufficient gestational weight gain increases the risk for fetal growth restriction and low birth weight. So there's a huge conflict in those two statements from the same consensus paper. So that's really challenging for our patients, and they feel conflicted as well. What are the recommendations? So the Institute of Medicine put these recommendations out, and you can see that we've got the total weight gain for different BMI categories. But are these guidelines relevant for women who have had bariatric surgery? So a nationwide population-based study, it was a matched cohort study, was conducted in Sweden from 2014 to 2021. Huge number of pregnancies. And so there was 6,338 post-metabolic bariatric surgery with the same number of case matched controls. And it showed that women with history of metabolic bariatric surgery gained less weight during pregnancy than women without a history of metabolic bariatric surgery. Women who became pregnant within 1 year after bariatric surgery had the highest proportion of weight gain below the international guidelines. So are those international guidelines relevant for our patients? So I'm just going to summarise what we can do as healthcare providers. We must educate our patients before they have metabolic bariatric surgery. And again, the whole integrated healthcare team, it's relevant for all of us to be talking about contraception, fertility, waiting times. We need to be aware of our own internal biases, not be judgmental if they do fall pregnant within that time frame. Let them know that they need to come back and see us as soon as they know they're pregnant. We want to see them every trimester, and let them know why. It's not because we're going to give them a scolding or tell them off for being pregnant. We're going to be there to monitor their nutrition and guide them through and work out the best pathway. Offer support and regular review during a pregnancy, and consider a shared care approach. And this is very much the approach we take in our clinic, where we do see them every trimester or more frequently if needed. And we communicate with their obstetrician and the tertiary hospital so that we're all on the same page. And I think they've been very open to us educating them as well about the needs of our patients. Acknowledge their fears about gestational weight gain, but also let them know it's normal. There are hormonal changes that are creating this, so particularly increased progesterone levels, increasing hyperphagia, having an effect on smooth muscle relaxation in the stomach. Towards the second and third trimester, we start to see that there's leptin resistance as well. So there's a lot of hormonal implications in pregnancy. And I think if we can understand that, all of our patients know the hormonal and biological and physiological impact from weight and the satiety hormones and the hunger hormones. So letting them know this same sort of thing is happening in pregnancy, and it's okay if they're feeling more hungry, because they have incredible fear of that and they think that it's going to continue that way. Reassure them that we have many options now that we can assist with gestational weight gain once breastfeeding is complete. And again, I'll talk to them about that at the very beginning of their pregnancy, so they know we're going to support them through that whole journey. And empower our patients with the knowledge to navigate their antenatal care and advocate for themselves so that they know they can't have a glucose tolerance test and why. They know that they'll need more frequent growth scans, and they can advocate when they're in the system themselves. So thank you. Now, I don't know if you want to go directly to a case, or shall we get everyone up first?
We'll get everyone up.
Get everyone up?
And I'll get out of the way. If we have 6 speakers up here.
Yep.
So you wonder why we've finished the talk so early. We want to have discussion. And the discussion we really need to have, firstly, is these people talking to one another. So you'll just have to wait a little bit. Paulina, do you have something you'd like to kick off with?
Can I have the microphone?
Might be down the bottom.
It's on the bottom.
Yep, it's on now.
Is it on now?
Here you go.
My voice is very loud, so I can, no, you can hear me. I would really like for them to discuss the idea, because I know Ida was representing problems that you may have during pregnancy, but I think the key issue in that is like if you need to operate, then you operate. Like watchful waiting is not for people that are pregnant. So, but I think that's kind of that's not maybe the main question. I think one of the main questions I would really like to hear the panel's thoughts on is that as the access to metabolic bariatric surgery globally is like 1% to 2% of the patients that have severe obesity. Yeah. And we have these young women that have been going and getting older and going through infertility treatments, but nobody refers them to the actual treatment that we know is successful. So I would like to hear your thoughts on that how can we achieve that? And then from a surgical perspective, I would really like to hear the idea, because the IFSO AS-MBS guidelines in 2022, the other main thing that was addressed in addition to lowering the BMI threshold to 35 was the increase of metabolic bariatric surgery in adolescents. And I think for adolescents, it would be in this context really crucial for us to understand what would be the optimal bariatric procedure, and that's actually, I thought, would be a more interesting surgical topic. So sleeve versus bypass in the context that a lot of as in adults, the majority are young females. So I think those are the key questions. And then thirdly, we need to educate bariatric surgeons of the idea of contraception after metabolic bariatric surgery, as we've had a lot of bypass and sleeve babies. So those would be my topics, but please feel free to address other issues too. But I think those are the main concerns.
I think if I present this case, and it might bring some of those issues out. We've got Tamika, who is a patient of mine, 27-year-old married female with 2 children, 2 and 4-year-old. Her weight was 102 kilos, BMI 36. She had already lost about 20 kilos with weight loss medications over the previous sort of 18 months. Medical history, anxiety, but not on any medications, mild asthma, and she'd had 2 normal vaginal deliveries. Both pregnancies were complicated by hyperemesis gravidarum, but she was otherwise had very successful, straightforward pregnancies, not on any medications. She had an uncomplicated sleeve gastrectomy in October 2023. 25 days post-sleeve gastrectomy, she's 5 weeks pregnant. She actually knew the date she conceived because she said she was so grumpy on her VLED that she thought she had to have sex with her husband that day. So she knew exactly when conception was.
I love that.
So, from the panel, what are your thoughts? Because I can tell you some of the thoughts, and she certainly did get in touch with her surgeon and got in touch with her GP, and the recommendations were for termination.
I can see what people think.
And I have got more to present, but I'd love to know some thoughts first.
Well, from a surgical side, I had this 3 times last year, but then after bypass. Actually, all 3 women became pregnant from sex they had the evening before the surgery. And that tells you that apparently something happens also, that they get very fertile directly after surgery, because otherwise you can't explain. So far, all girls, by the way, which makes sense. I would say, yeah, let's give her the best help possible, but termination, why? I mean, on average, of course, you hope that it will be a healthy kid, and in most cases, it probably will. So as long as the care is there. But abortion, a stupid idea.
Mary, nutritionally.
Well, nutritionally, but also, first thing I always say is, because I've just been contacted here about one patient who's just become pregnant. And I always say congratulations, because we know that's what they want. And also just with experience of having worked with patients with uterine switch who've actually had normal outcomes, a little bit more relaxed. So actually, usually just like anything, just concentrate more on the quality of the diet. But I think the hardest thing is if they start with morning sickness and struggling to eat and struggling to gain weight, that becomes then a wider issue and more people getting involved. Yeah.
I think you made a very good point there of saying congratulations.
Yes.
You know, again, this is a woman's choice as to what she's going to do. So she called me quite upset and distressed with those, you know, directives from her surgeon and her regular GP. Unfortunately, similar to her previous pregnancy, she had severe hyperemesis gravidarum, vomiting after all food and fluids. This is 5 weeks post-sleep. Are we worried about that, Ido?
Yeah, of course. The solution was already given, but in the end, yeah, she does need to get something in. I mean, especially looking at, of course, things like thiamine and etc. In these early stages. Yeah.
She wasn't tolerating supplements or PPIs. She was having regular ondansetron and metoclopramide with minimal benefits. She had several hospitalisations. She had some IM thiamine in the clinic, but also went to hospital for IVT, IV fluids and IV thiamine.
Can I add like one additional question, because I think it's important of women for childbearing age. We don't want to operate if they're pregnant, so you need to have a preoperative pregnancy test in the protocol.
So I checked back in the records because that was my first thought, and it was negative. She had a
I get it. That can happen.
She had a serum test, so I think it was, as I said, she knew exactly.
Yeah,
what
but
she
that would be, I think, an important point to raise, because then, of course, we would postpone sleeve gastrectomy at that point.
Absolutely.
But
So
can I
we
see-
had a few unplanned pregnancies early on, and all of our surgeons now.
Can I see any hands who does it on the day of surgery then? Because that's the question you're actually raising.
Sorry.
So determining whether they are pregnant on the day of surgery, who does that actually?
In New Zealand, it's compulsory for any female
Yeah.
Okay.
55 to have a urine pregnancy test.
For any surgery.
So it wasn't going to be positive for this woman. And her blood pregnancy the day before.
Okay.
Yeah,
Yeah.
yeah.
But considering there were like 13 New Zealand dietitians in the room, it's 13 hands then, and the rest was silent.
No, I had my hand up, and Johan had his hand up,
Okay.
so
So that's like
so
2%
that
of
should
the
be
audience.
standard bariatric practice to have that test.
Absolutely.
Can I ask a question? This is my naivety because I'm a paediatrician, not a surgeon. How clearly this was, we're talking about 25 days post-sleeve gastrectomy, but say, what about that severe, hyperemesis happening very soon after surgery? Maybe the pregnancy was missed or something like that. Does that pose, what sort of risk does that pose to the actually operative field?
Well, hardly any, because I've done surgery on a 3-month-old female that appeared to be pregnant afterwards. That didn't came out of the test because the test was inconclusive, let's say. In the end, so far, not really much, as long as you provide good care. And I don't do sleeves, especially in these young women. That's my opinion. You're better off, let's say, with a different type of surgery because you don't have all this. So especially in these cases, I'm always very happy they have something else. BPDDS, totally different story. Okay, that is not fun to have that around this but the vomiting, etc., is already relatively common after a sleeve, let alone when you're pregnant and do have these complaints additionally.
So would you be worried about a sleeve leak?
Sorry about it?
Like with all the vomiting, would you be worried about
Oh
the
yeah, of
actual
course.
sleeve itself?
Yeah. I would not consider making it a bypass or anything at this point in time, but I would feed her with a nasal tube. Yeah.
Yeah, that would increase the leak rate, but
Yeah.
of course not probably markedly at that point.
Yes, Nick.
Sorry, just in women who don't want to necessarily fall pregnant, what advice do you give them about contraception or the oral contraceptive pill before and when they go on a VLED? I'm interested in, some people say nothing, and I'm just interested.
So we always at our clinic advise that oral contraceptive pill is not absorbed effectively. We can't rely on it. It already has a high failure rate anyway. And then you put a bariatric procedure on top of it with malabsorption, that increases. So we always advise them. We prefer long-active reversible contraception. I think something like a Mirena is ideal because it also manages the menorrhagia that they can often get and helps with retention of iron levels. But Implanon is a suitable, option as well. At the end of the day, it is a woman's choice though, and there are ones, this particular patient was using condoms. She knew all the advice and she had it all in writing in her file, but she chose to use condoms.
So this might be perhaps a very dumb surgeon question, but after a sleeve, is actually oral contraceptives absorbed differently?
It is.
Yeah? After a bypass, I know.
Yeah.
But why?
There is the more rapid transit, so we've had a clinical pharmacologist looking at that data, and certainly there is change. As I said, it already has a poor, a significant failure rate. You then put a procedure on top of it, a procedure where you don't want someone to fall pregnant in the first 12 months. So why not choose something that's going to be more effective?
No, I fully agree, but it's more that I can't grasp why, because it's only if you do a sleeve, let's say, within 4 centimeters of the pylorus, indeed it changes 20 minutes.
Yes.
On average, from mouth to backhand, it's 24 hours or something.
So there has been some
So
data
adding
looking
20
at
minutes
both progesterone and estrogen and slight reduction. And look, it's different for, everybody absorbs things differently, but there is that possibility that there is a slight reduction in those parameters.
And also, for other medications, there's clear evidence that also sleeve affects,
Okay.
in addition to
I know a
bypass. So
couple of
there's
them,
data
but
on that.
That has to do with acidity, and
Yeah.
the hormones are not affected by the acidity, but
So she went into premature labour at 35 weeks. That was May this year. Baby Hunter was born via normal vaginal delivery. Birth weight was a surprising 2.9 kilos because she continued to be quite sick throughout the pregnancy. Apgar's BSLs were good. She gavage fed in hospital with express breast milk. She had a lot of support for that. She left hospital day 10. The baby left hospital day 10. She left before that. Again, with good support, and was able to continue breastfeeding. So I saw her 3 weeks postnatally. Baby was gaining weight well. Mum fully breastfeeding little baby Hunter. Current maternal weight was 75 kilos with a BMI of 26.6, remembering that her pre-surgery weight was 102 with BMI of 36. Mum was feeling amazing. And that's actually a photo, and Mum has given me permission to post that photo. And so I think, this case raises a lot of questions, and I have to say that I was pretty terrified at the beginning, particularly with the ongoing hyperemesis. But then when you have Mum and Bubs coming back at 3 weeks postnatally, whose decision is this? So I guess, throw it out to the panel now. I've done enough talking as to whether anyone has any comments about the case.
well, I mean, these kind of things happen. That's life. So we all try to do our best in informing our patients not to get pregnant within, let's say, a year or 2 years, depending indeed on what you're using. But it happens, and as long as you realize it happens and have in place what is required to help these patients through, and apparently healthy babies come out of there. So yes, it's worrisome for the patient and for us as clinicians, but so far, 9 out of 10 times it works out. In my
And I think one of the important things with this lady, we had an incredibly supportive obstetrician. We had a fetal medicine specialist, we had a physician involved, and a dietitian and myself, and there was regular communication between all of us. And this lady actually wanted to deliver in a private hospital. The obstetrician at first said, no, this needs to be public, this is high risk. She had had poor experiences with her previous 2 pregnancies. So she did actually allow her to deliver in a private hospital, obviously with a lot of support. And then they were, I think, sent to the public hospital after delivery for extra care for the baby. And again, it's listening to a woman and listening to her choices and thoughts and feelings over this.
There was Professor Moll.
Yeah, I'd like to add, we should not forget that the absolute risks are important for the individual woman who gets pregnant. I showed some data about prematurity and growth restriction that happened twice as much, but 2 times 5% is 10%, which still means that 90% is going within normal ranges, and as is shown here, a case of prematurity is .NET severe also. So I think it's better to advise to delay a little bit if that's controllable, but if it happens early, like in this case, yeah, I think congratulations is the best response.
I think
And
there was another...
don't panic and give supportive care.
maybe for you, Ben, another question there. Long-term outcomes for mum and baby, like looking at that weight loss that she had during the pregnancy.
Yeah, I would say limited data to state that is a poor outcome. I think in general, as compared to a normal pregnancy, yes, given the data, for example, that Barker presented, but we don't know exactly. And I mean, what's the alternative here? Interruption of pregnancy? No way, of course. So you just have to deal with that, and don't bother too much, I would say, if it happens.
Because also, of course, not all macronutrients are available, but the starting point is completely different than the hunger study that you showed us. Huh? So these are women who actually at least have some additional calories, at least in some form on there. Protein-wise, perhaps not, but it always reassures me that even in the patients that actually have quite severe deficiencies, which already have lost weight, they waited like 2 years, etc., healthy babies come out all the time. So Laura Hoshin, who's one of my PhDs, did a couple of great studies on that. And so far, we did find the same data as you have already shown us. On average, it's pretty good. And I'm actually convinced that if you waited and the chances for the kid of getting obese themselves is much less than they would have been if they were born out of a patient with obesity class 2 or 3. Because you get fat at a little bit higher glucose level in your uterus, so you are a little bit used to higher glucose levels. But that's my personal. So far, you see many kids getting born out of patients with obesity class 2 and 3 that get obesity class 2 and 3 in the end themselves or start growing. And it all has to do with family tradition, of course, but sometimes it's relatively early that you wouldn't expect it either.
If I could just comment about the child, I mean, absolutely wonderful to see a healthy child come out of that, albeit somewhat preterm, but given good care. And breastfed, fantastic. Great start to life. #1 dietary guideline in Australia and around the world, or after enjoy a wide variety of nutritious foods, is support and encourage breastfeeding. It's actually the #1, support and encourage breastfeeding. Absolutely fantastic. But then don't make the mother who is unable to, chooses not to breastfeed, to feel anything other than supported in her decision. I do want to point out this child, we know there's a strong genetic predisposition to obesity. Clearly we know that. And whatever happens, this child will still have probably a genetic predisposition to obesity along with her older siblings. And that means that it's even more important that parents are encouraged to provide a healthy home environment, food environment, nutrition environment, physical activity environment, screen environment, sleep environment for this child and these children throughout the time that they're with this family. And that would be around that point. That would be the most important issue at this stage, just being able to ensure that there's good, healthy monitoring of this child, normal routine clinical care, of anticipatory guidance of this child through her life, along with the siblings, and encouraging the parents to have this mum, this dad, to provide really great role modelling around a healthy environment. That's the key message to provide here, and with all children. And so that includes regular growth monitoring, because you want to pick up failure to thrive as well as perhaps excessive growth, and you want to ensure that the child is able to go on to solids at an appropriate time and not be exposed to too many screens, almost impossible to do that, has healthy sleep routines, all of those sorts of things. That's going to be important for this child long term. But this mum is a busy mum. She's already an experienced mum. She may well be doing this already, and we just encourage her to continue to do that. But this child will be at slightly higher genetic risk than the average kid in the population, so might just need that extra support.
It's a perfect time to do it, isn't it?
Yes.
No, that just reminds me of a case that I had, and it was a woman, and she and her husband used to come and bring their 3 or 4 year old, and the lady had started snacking, and we ended up talking about not having certain foods in the house, just like crisps and biscuits and chocolate. And she said, "Oh no, I have to have them because my child's underweight." And yeah, but her husband was so shocked because he'd never heard his wife say this. And I said, "Why do you think your child's underweight?" And she said, "Because I can see his ribs." And both me and the husband said, "He's normal." And it was just because of her experience and how she thought her child was underweight and needed extra food. So it was actually really good because her husband was there, very supportive, and we got that sorted. But make assumptions, yeah.
Yes. And I just want to point out, it's actually very challenging for parents to raise children in this environment in which food marketing is so pronounced and is there everywhere. I remember my sister writing to me when she had a 2-year-old, and she was writing to me because I was overseas, and she said he picked up a plastic W, and turned it around and says, "Look, Mummy, look, Donald." And she said, "I'd never been there before. I'd never taken him to McDonald's, but he already knew what an upside-down W meant." And he's now the father of 2 kids. He's 40. That's how profound that food marketing is. So it's
everywhere. Look, it's on the plate as well. McDonald's. They even tease us with it. Huh?
That's from Melbourne.
That's Melbourne. It's second best city, not the best city in Australia. Sorry to those who are local. I just want to. That's the reality in which children and young people are growing up, and the parents are now. We've normalised unhealthy eating rather than normalising healthy eating. And so that's a challenge we have, and so it's great to raise those issues, and we just need to do it in a supportive environment. It's a really hard task being the parent of young children and adolescents for that matter, and we need to be a child and an adolescent who want to be healthy and well and fit, and so we need to support them.
Bryony, you had a little case that...
I did. Do you want me to find it?
I think there were a few questions. Should we give the audience a chance?
In the meantime,
Because-
go look it up and
Yeah.
a few questions.
yeah.
Sorry.
Any questions from the floor?
Yeah, there was,
Anyone
I think,
here?
like 2 here.
Thank you for that great presentation, everyone. Teresa, thanks for sharing that incredibly emotional case study. My question was, I guess, to the panel. You mentioned hyperemesis. Did your patient needed to be enterally fed because of the symptoms? And I guess my question to Ido is, in hyperemesis, it's very difficult to put a nasogastric or nasojejunal feeding tube because the vomiting, obviously, surgeons are worried about it actually vomiting it up.
It does happen, but sometimes it takes 2 or 3 turns, but in the end it always works. So you can do it, and in the worst case, of course, you can do a very small geogynostomy, but never done that. In the end, people vomit, they do, but if you put in the line deep enough, it won't come out. So, but you sometimes have to put it in a meter additionally, so you have to then order longer feeding lines.
But the threshold of putting that in, of course, you have to. That has to be a very severe case.
Firstly, thank you to all the speakers. They were amazing presentations. My question is going to be directed to Bryony, actually. Your talk on stigma was amazing yesterday as well. I think we're all here and we can all understand the issues of stigma. But if you think about, because we're mainly talking about women, they are stigmatised throughout this whole journey. And if you think of this fertility journey particularly, it's quite evident. You know, they say they're stigmatised before because they're overweight. They do something for themselves, they have bariatric surgery, do an amazing job, lose a lot of weight, then get pregnant, feel stigmatised and are nervous at coming back to us because we've told them about the risks and the fact that they need more pregnancy care, and we're all supportive of that, of course. And then, you know, they don't want to gain too much weight, but then if they don't gain enough weight, then we talk about the Barker hypothesis and the fact that their unborn child's going to have risk for life. So the answer, my question is, at all of these points where women are particularly stigmatised, when they do get pregnant and then we say, we're going to be supportive of you, you need extra care, but geez, now you need to go to the high-risk pregnancy clinic. How do we actually, I mean, I know in our clinic how we deal with that. We just wrap our arms around them and say, we're going to support you and you need more care throughout your pregnancy so we can make sure that this pregnancy goes really well for you and the baby. What terminology do you suggest we use instead of high-risk pregnancy?
It's a fantastic question. And so we've done a lot of work with women with lived experience of weight stigma in pregnancy, and that's where this vignette came from, actually. And the consensus, the story we get from women is that to just really think of them as the core of the appointment. So, you know, you're busy, you see a lot of patients throughout the day, they've all got different needs, but for that woman, that moment of her day is probably the most important part of her day, that appointment that she's been, waiting for. And so I suppose if you're talking about terminology, it's really just being woman-centred or patient-centred, making sure that they understand the risks, but delivering them in a way that shows absolute risk, not relative risk, where possible, and avoiding terms like obese. Can say higher weight or larger body if you need to talk about in general terms. Obviously, when you're talking about BMI, that's a very specific thing, just making sure the patient feels respected and listened to. And if you have to make a decision about sending them to the high-risk clinic, explaining. They're smart people. If you explain it and they can understand and make their own decisions with your support, I think that's the best way to go.
Maybe one extra. So I would say patients are interested in absolute risks, doctors in relative risks, and nobody is interested in p-values. So I think it's really important to stress that absolute risk. The other thing, just an observation, I think Ido and I are the only one who bike without a helmet. So we live in a society that is obsessed with risk, really. And I have come from the Netherlands to Australia, and every day I have to get used to how this society is obsessed with risk. That is in all of us here, right? Yeah. If you just bike, well, I wear a helmet because I don't want to upset people, but then you get some roadworks and they're flagging like hundreds of meters in front. All people are flagging, slow down, etc. So, and that is in all of us, and we bring that to our patients. I mean, I have stopped thinking that I can change that culture here. But if you really want to make a difference, I think that is a very important issue. And the other important issue, I think we have several presidents and past presidents of society, is the comment on the food industry and how that. I mean, there is for me a paradox in having this whole group of people working dedicated on that topic, and then go out there and see how food is marketed, right? I mean, we stopped smoking also. This needs action from these societies here, us, to governments to change that.
Agree.
If I can just come and speak on behalf of World Obesity Federation, we have a presence in a couple of weeks' time at the UN General Assembly just on these specific issues around the WHO action plan on Obesity Action Acceleration Plan, but a large part of that is around food systems and food policies. But as you can imagine, the commercial determinants of ill health are alive and thriving, and trying to deal with that is challenging. Within Australia, I'm certainly involved along with the Obesity Collective and many others in advocating for a whole range of strategies, including improved access to clinical care, costs, etc. But around sugar-sweetened beverage tax, that's one thing we like it. But Australia is a sugar exporting country, and neither major party wants to go down that road. So we've got a lot of challenges. There's a lot of people working hard on this, but it's hard. We didn't get to this. No one thing causes obesity. No one thing is going to turn it around. And a lot of it relates to modernity and the world in which we live. It's hard. But I agree with you. We need to talk about those things too. this case.
We've got one question or two from the audience. We've got a couple of minutes. Any pressing question? Any questions for
Can
one
I just
another?
say this
Yeah.
vignette? I think that's an absolutely appalling way for any clinician to interact with someone who comes seeking help. Maybe this clinician didn't know how to help this particular woman, but he or she, this clinician, could have directed this woman to someone who might have been able to help her think through, how can I have some weight loss, or how can I become pregnant? How can I be helped with my infertility and being helped with my obesity?
Ben?
I think that's an appalling
Ben, do you have
situation.
a suggestion? How would you
I mean, I've commented on it. It's really there are many societies in the world who have thresholds for weight or BMI, and I've argued it, discussed it. It's completely inappropriate, right? It's just you should support women and their families in achieving weight loss, but if that doesn't happen, you should not convict them by denying care. So for me, this is really unbelievable. So is it unbelievable to hear that in the UK there is a BMI of 30 to get access to. It's ridiculous, really. It's simply, there is one word for it, discrimination.
Tomorrow's plenary session that John and I and some other people are involved with is to talk about at least where we're got to so far with the Lancet Commission on diagnostic criteria for clinical obesity. We won't be able to tell you the exact criteria because they haven't been published yet, but we'll be able to tell you some of the thinking around this. But one of the issues is to get around hard BMI criteria. It's about health. Yes, BMI is part of your assessment, but actually it's about health and other ill health and other issues that you need to take into account. So this hard BMI criteria, beloved of health service managers and some insurers, is actually anti-clinically. It's not helpful for people, and we'll have at least some discussion on that tomorrow.
There are so many false dichotomies, aren't there? Where we look, this has been fantastic. I really want you to thank the 6 presenters. I thought we got a superb